Today we'll see something about hypo and hyperthyroidism. It's a basic chapter that we deal in our day in and day out basis, but we will have to know about certain intricacies of hypo and hyperthyroidism. The problem lies in the exact diagnosis of that particular condition, and sometimes we do face problems with titrating the doses and what sort of hyperthyroidism should be given, what sort of treatment. In that way, we actually differ in our opinion. So today we'll have a very utter basic discussion about hypo and hyperthyroidism, the possible MCQs which your NEET SS may ask, and I have just have some leftover portion yet to be covered from the thyroid basics, which I will cover towards the end of this chapter. But we'll start with the chapter fresh, that is hypo and hyperthyroidism. So to start with, the first thing is hypothyroidism. So any deficiency of thyroid secretion, you call it as hypothyroidism, right? So it could be directly a problem right at the level of your thyroid gland, right? Or at the level of your pituitary. So this is the basic cause. So when we conclude that there is a problem at the level of your thyroid gland, we call it as primary hypothyroidism. And when a problem lies at the level of your pituitary or in the hypothalamus, and thereby you have a problem secondary to that in your thyroid gland, you call it as secondary hypothyroidism or central hypothyroidism. So basically, the primary hypothyroidism happens with any sort of infection or inflammation or autoimmune conditions, and sometimes it could be a iatrogenic condition also. The most common cause for hypothyroidism worldwide is iodine deficiency, so which is a reversible condition. But in iodine sufficient area, with onset of all this universal iodization program, right now we have entered into a state of iodine sufficient zone. So in our country, especially in countries where the iodine is in sufficient level, the most common cause would be autoimmune. The second most common cause would be iatrogenic. Okay. So when we look into iodine deficiency, you call it otherwise as endemic goiter. We would have discussed about iodine deficiency in our previous thyroid basics. Like we actually measure iodine deficiency with the prevalence of goiter in that particular area. When the prevalence of goiter crosses 5%, we consider that area to be endemic for iodine deficiency. Okay, so based on the percentage of goiter that is being detected in that particular area, we call it as mild, moderate, or severe iodine deficient areas. Okay, and similarly, right now in nowadays we are measuring urinary iodine compositions also. We do measure the salt iodine content also, household iodine content in the salts also. And this is how actually the endemic goiter goes about. This is right now turning into a very rare entity. Okay, sometimes in age-old days, there was a condition called cretinism, which was attributed to this endemic goiter and all. The reason being in cretinism, the mother would be already iodine deficient. On top of that, the child will have a thyroid gland, but the thyroid gland cannot function to the maximum because of the severe iodine deficiency state of the mother. So because of that, both the maternal as well as the fetal higher thyroid levels would be very lesser. And that is the reason why the child would be a neurocretin. And when this happens on a later phase of the gestational age, like initial phase, when the neurological development happens, the iodine levels were okay. But towards the end of the pregnancy and after the delivery, if the child is entering into a severe iodine deficient state, they call it as mixed hematous cretin. So in mixed hematous cretin, usually there won't be any permanent neurological damage in that particular child. So this is the basic difference between a neurocretin as well as the mixed hematous cretin. Okay. Moving on to the autoimmune causes, the most common cause, as we all know, is Hashimoto's thyroiditis, right? So in Hashimoto's thyroiditis, what happens? The basic entity is that when your body has certain polymorphisms at the level of your HLA, the major histocompatibility gene. So if you have a problem with identifying your own antigen as a foreign antigen, then automatically your body will start developing antibodies against it and will start destroying the particular antigen, right? So that is how autoimmune effect comes into play. So for that, there should be some genetic predisposition on first hand. So usually the person who is having the particular autoimmunity will have HLA dysmorphism. So there would be some HLA mismatch. So you will have a HLA DR2, DR3, 5 polymorphisms and all. Sometimes you will have CTLA4. cytotoxic T lymphocyte associated antigen 4, that mutation, and PTPN mutation. All these mutations or mutations as well as polymorphisms, they are associated with Graves also. So basic thing is that because of all these, the CD8 cells starts attacking your thyroid gland, and because of that the thyroid antigens are being exposed outside, and because of that lot of antibodies starts generating, and once these antibodies are generated they start to fix complement, and this complement mediates the further damage of that particular thyroid parenchyma, and on a longer run this develops into a chronic inflammatory state and slowly towards fibrosis, leading to a deficiency of that particular hormone. This is how a autoimmune thyroiditis gets into play. Okay, and the next thing is hydrogenic causes. Usually post surgery, when a total thyroidectomy is being done, after that the patient will never have any leftover gland, and that may they may be rendered hypothyroid in a hydrogenic basis. Sometimes this can happen after giving radioiodine ablation to the patient. See, in Graves disease and in autonomous nodule in thyroid glands also, we do give radioiodine ablation. So sometimes around 30 to 40% of these individuals, because of the iodine-induced, radioiodine-induced nuclear damage, they end up having permanent hypothyroidism. So that could be a cause. And any cancer, for that matter, any cancer, head and neck cancer and all, if they are subjected to external beam radiotherapy instead of radioiodine ablation, if they are being given radiation also, because of the radiation, there could be a damage. And sometimes when we use drugs, especially of late, all these immune checkpoint inhibitors that are being used in cancer chemotherapy, and certain other drugs like interferon gamma and other immunologicals and biologicals, when they are being used, they may damage the thyroid gland. Because of the immune reconstitution syndrome, there would be a damage to your thyroid gland, and this may lead on to a hydrogenic hypothyroidism. This can happen with lithium also. This can happen with amiodarone also. Clear? So these are all the causes for hydrogenic hypothyroidism. So let us just move on to the further thing. So this is the table given in Harrison's, which slowly tells you what are the causes of hypothyroidism. The autoimmune hypothyroidism, the most common thing is Hashimoto's. Hashimoto's is the initial stage of active inflammation, but slowly with more and more inflammation, what happens is that there would be damage, there would be fibrosis, and finally they'll end up having atrophic thyroiditis. Okay, and hydrogenic, it could be due to iodine ablation or subtotal or total thyroidectomy, or due to external irradiation of the neck for any lymphoma or cancer. And regarding the drugs, whenever you give iodine excess also, lot of iodine may cause stunning effect. That's called transient hypothyroidism. What's that effect called as? Wolff-Chaikoff effect. So amiodarone also has a lot of iodine by its molecular weight, around 37% to 60% of amiodarone would be iodine. So that causes that. Lithium, antithyroid drugs, PAS, interferon alpha, cytokines, aminoglutamide, and all those tyrosine kinase inhibitors, all these things, they cause immune reconstitution syndromes. Okay. And because of that, there will be a collateral damage. We call it as bystander effect. Okay. And second thing, to put into clear words, you will have to tell about congenital hypothyroidism. So congenital hypothyroidism can happen at any level, right? So it could be directly at the level of your thyroid gland or at the level of your pituitary or hypothalamus also. Whenever there's a problem with the structure, we would have seen in the previous thyroid basic chapter, whenever there is athyrosis or agenesis or hypoplasia or ectopic thyroid, ectopic glands can develop, but they may not develop in a proper milieu. So the proper development of the gland wouldn't be there. So will be their functioning. So that is again a main reason for hypothyroidism in congenital conditions. And sometimes in pituitary reasons and hypothalamic reason, there could be obviously a structural cause. See, for example, there could be improper development of your hypothalamic neurons, and because of that, your pituitary wouldn't have developed properly. And sometimes the transcription factors in the pituitary would be not functioning properly. So, for example, if you see the earlier transcription factor, PIT1, PROP1, HESX1 and all, they are involved in multiple pituitary hormone deficiency. So, along with the growth hormone deficiency, along with the cortisol deficiency, along with that, there will be thyroid hormone deficiency. So, there will be a multiple pituitary hormone deficiency. Sometimes only the thyroid isolated TSH can be deficient. Okay, so that can also happen. And similarly, the thyroid transcription factors, as I told you in the previous chapter, the TTF1, NKX2, which is actually the TTF1, and PAX-E1 and FOXE, all these transcription factors, they are involved in the thyroid initial formation, differentiation, survival, and everything. So when they go off, automatically they present with congenital hypothyroidism. This is about the structural part. Sometimes the structure may be normal, but the functioning part of your thyroid gland will be at ease. Okay, so what happens is that there could be normal structure, but there could be a problem with the sodium iodide importer pump. There could be a problem with PPO enzyme. There could be a problem with thyroglobulin per se. Okay, there could be a problem with deox enzyme also. So because of that, the machinery which actually generates the thyroid hormone would be at fault. So this condition is called as dyshormonogenesis. So these are also important reasons for hypothyroidism, and based on the level of involvement, it can be either primary or secondary hypothyroidism.